gentlemen, it's the third day of the conference. I'm actually a little bit sad because this is the closing session. This is the closing plenary session. Sad, but also very happy because I've seen so much great work. There have been such a lot of networking, so many great meetings, people talking about their projects, people having debates on certain topics, people drilling down into lots of things that concern all of us when it comes to research, when it comes to the science of trying to fight the good fight, as I always say when it comes to oncology, when it comes to cancer. We have a great session lined up today. What I wanted to say, first of all, we are going to be having some speakers in the sessions to come who are going to be speaking in French, at least 2 or 3, so please don't hesitate. I know you've got the headphones also French speakers, you have translations into English, but do please come forward if you need to have a headset to hear the English translation of some French speakers. So we'll give you a moment just to come forward and to grab your headphones. There are plenty to go around, so thank you very much. I wanted to also say that I'm so pleased. I had a little chat with the powers that be to make sure that we had great weather this week, and I'm delighted to see that the sunshine is strong, almost a little bit too strong. We're only May, and it feels like summer today, but it's great that we have the air conditioning inside, but it's great that we've had this wonderful weather for all of you here in Lyon. Hopefully you've had a chance to have a look at our beautiful city between sessions in the evening. Maybe even this morning you were up at 5 o'clock, the crack of dawn, for a run or for a walk around the old city. Hopefully you've been able to get a taste of Lyon as well, the wonderful food here. I think most people have got their headsets now, so I think we can begin with one of our closing sessions. We have a Ministerial Roundtable coming up in a moment, but before that, we want to put the focus on cancer control, resilience when it comes to cancer control. The title of our first session this afternoon is Cancer Control in Crisis, Resilience, Economics, and Policy Imperatives. And I'd like to call from IARC, from the Cancer Surveillance Branch, our moderator for this session, Dr. Isabel Soerio Mataram. A warm round of applause, please, for Isabel.
So, good afternoon, everyone. If you're standing at my point, I can invite then the panelists to speak, to sit down in their places. If you're sitting now, if you're standing in my position, actually, I can't hardly see anyone because of the lights that's coming here. So it feels like the room is full, but maybe the room is actually quite empty. But, so today, this is really the last 2 hours that we are here together. It's been a long 3 days. I am very excited. I'm very tired as well, as a lot of you, I'm sure, are. And then before we're going to go ahead into the ministerial discussion and panelists, we're going to talk a little bit about crisis and cancer. And then why crisis especially? Because then really crisis, when we have a health system, a cancer system, an intersectoral system that is resilient to crisis, we are building a system, a cancer control that is much more sustainable, that is much more long-term. And that's why I want to use the hook as then the crisis at the moment. And then we'll discuss what then our panelists think, how can we have a more resilient cancer control program in our country, bringing together what we have been discussing in the last 3 days. Before I do that, I think I have a presentation that I'll move, but then when we're talking about crisis, the first time I presented this in IARC, in one of the participating states discussion, when we were talking about crisis, there were a lot of discussion immediately saying, but there are a lot of different types of crises. I had a crisis this morning. So my daughters, I have two girls, they're twins, they're 17 years old, and every morning there's crisis with them. They wake up very, very early because they need to prepare themselves, of course, to go to school. And then one of them this morning couldn't find their headphone. And it's a big crisis. I mean, everybody had to wake up because she cannot really go to school without her headphone. She runs around, she opens all the things, she was screaming, she was crying at some point. It was a really big crisis, only because of a headphone. Now, that's one small little crisis, and I'm sure every one of you here have been faced with crisis. Not so long time ago, this feels like a long time ago, there was the COVID crisis. I think everybody can remember that, and my daughters had crisis every day then on that crisis because they cannot contact their friends, etc., etc. So, but imagine if you were then a cancer patient. We did a lot of studies of cancer control during crisis, during COVID, and then there's now a lot of other types of crisis, climate change, natural disaster. Imagine having that living experience as a cancer patient and having then to live through crisis at the same time. So in this session, we'll discuss that. And then this is the first number that I'll bring out. It's 1.6 million. It's a big, big number. I'm not going to ask, I can ask you what do you think this number is. But this number can be a lot of different things. I was thinking about, this is actually the size of population living in Lyon. It's a bit less in Lyon. Marseille is 1.6 million, but this is more or less a stadium that is filled in with people. And then this stadium, if you multiply it by 16 times, you'll get then that 1.6 million people. And then there's a lot of cities in the world. I don't know whether some of your cities in here. I come from Jakarta originally. Jakarta is now over 40 million people, so it doesn't make it into the 1.6 million. But there's a lot of cities around the world that have that as large as of this 1.6 million. This is when you see 1.6 million in kind of an area. And then this is 1.6 million that really then put together, that really then kind of lead us to this project that I'm presenting here very briefly. So in IARC, when COVID hit, we were asked by the member states to look into the impact of COVID on cancer patients, on cancer in general, and then into health system in general. This is then where the IRCC project started. It started actually with other different projects at the beginning with Richard Sullivan, Karen Canfel, and then when COVID finished, then this project changed within IARC, within then an initiative that is looking much more into resilience in cancer control. I'm not going to talk much about then this project, but this project really then have three aims. It first then look into monitoring cancer data across the countries. We use a lot cancer registry data. That's where our group is, CSU branch come from. We evaluate in depth what is happening among people living experience of cancer and people living in crisis. And then at the end, what we want then to give back, of course, giving back tools so then countries are much more prepared when they were then living in crisis, and then when they're to have them to ensure that countries are having a much more resilient system. So with that to end, I will then introduce our panelists today. First is Lisa Stevens. Lisa Stevens is the head, the director in PACT, so in IAEA. She will tell you a little bit more about IAEA and about PACT. But before that, Lisa, I knew Lisa when she was still in the US. So she was working at the NCI at the time, at the Center for Global Health. But then she moved in 2019 to the PACT. Lisa, can I ask you then a bit of a personal question? Why did you move to PACT? What was your motivation to move there?
Well, thanks, Isabel. So I loved my job at the NCI Center for Global Health. But I was also looking towards the PACT team as one of my dream jobs. So we had worked with them in supporting ministries of health in comprehensive cancer control. And when the PACT position opened up, I couldn't resist it. So I moved my entire family from the US to Vienna, Austria, and it was a fantastic move 7 years ago.
Well, probably you didn't have adolescents. If you have adolescents like myself.
They were 2 teenage boys going into high school.
So I can imagine the difficulties. That must be a crisis by itself. Then the next speakers we have here is then Dr. Rasha from the Gulf CDC. Dr. Rasha Al-Fawaz has spent her career in the Saudi public health at the Ministry of Health, but then today she is really then working much more with the public health program at the Gulf CDC. And then when we're talking about the Gulf, especially now, I think everybody is aware that the Gulf countries are some of the wealthiest countries in the region, but then having that said, it's also countries that are located in one of the most complicated, if I may say it lightly. Rasha, what is the challenges? What do you think is the most interesting part of your work within the CDC, Gulf CDC?
Thank you, Isabel, and thank you for having me in this panel discussion. So the Gulf CDC, maybe there is a challenge and also there is a positive or a strength that we share, all of us, the same risk factors. We share the same roots, so we have a lot of commonalities and similarities. So this is the challenge, but again, the challenge now, having the recent crisis in the region, show us that the crisis cannot be usually and always only something like COVID, but it might be something political, but also it will affect the health. So this is one challenge that we really learn from, and we respond because we have that experience maybe previously from the COVID. But again, these similarities give us the strength how we can really work together and utilize our efforts together.
Yeah, and then I think working together in a region must be also very rewarding rather than working.
It is really.
The last speaker that I have here is Madame l'Ambassadrice Amprou, who is then the ambassador for global health in France. She actually started her career as a hospital director in Paris. And then after that, she moved really then through different task forces and has been involved in a lot of different crises. I can name them here: Ebola, the COVID, you were also very much involved. Then you spent a lot of discussions around the pandemic agreement. So this is also then another question: why did you move from your role as a hospital head going then into a much more global health work that you are doing today?
Thank you very much. I want to avoid a crisis here. As we are in Lyon, I will speak in French. Otherwise, I will have a crisis with my Ministry of Foreign Affairs. Alors, la question pourquoi, je ne sais pas répondre, sauf à dire que c'est une succession de crises aussi personnelles, puisque je suis arrivée dans le secteur de la santé par hasard. J'ai construit une stratégie très sophistiquée pour quitter la santé et ça a été un échec total. Mais je n'ai jamais été aussi heureuse de cet échec. Et finalement, cela m'a amené d'une gestion d'un établissement public, un hôpital, à une gestion de crise Ebola, une gestion de crise Covid, avec des similitudes, avec des différences. Et ça m'a amené, donc, qui sont des crises sanitaires, à gérer au niveau local, régional et national, et ce qui m'a amené à des crises diplomatiques quand il s'agit de négocier à 194 États des États membres. Et finalement, en s'appuyant sur une expérience locale, nationale, pouvoir apporter, en bon français, ce background au niveau international et surtout voir les interdépendances dont on n'a pas toujours conscience. Alors vous, ici, oui, vous avez conscience des interdépendances. Mais pris dans le quotidien d'un hôpital, pris dans le quotidien d'une politique nationale, parfois, nous oublions les interdépendances internationales. Et quand on parle de crise sanitaire, de sécurité sanitaire, on dépend tous des uns et des autres. Et voilà pourquoi j'ai pris une casquette internationale en tant qu'ambassadrice et en tant que présidente d'United.
So, La Madame Ambassadrice just said something about failure. And then it reminds me something that, and I think, I can't remember who said this, but someone who is very, very famous, Churchill or something like that, that you only learn or you only succeed if you had failures. And then you, in order to have success, you should do a lot of failures. And then I think Madame Ambassadrice mentioned that, and crisis is probably one of that as well. I know it's not nice to say that we should be facing crisis, but through crisis, actually, we can learn a lot. There is a lot of silver lining that we gain from crisis. So back then into then the question, what really then the PAC, the IAEA can do for this? So the PAC mission, they work really with a lot of different countries around the world, and on the ground that can be quite fragile, sometimes then really with conflict or crisis. So when they are in really active crisis, IAEA still get into these countries and continue then working in collaboration with these countries. So what are then the most important things you think Impact Mission, PAC Mission can do? And can you give us a few examples then from some countries where then you had to face these challenges?
Sure, thanks, Isabel. So first I'll say that the International Atomic Energy Agency has a broad mandate in the peaceful uses of nuclear applications. For those of us here today, what that means is really how do we use nuclear techniques for health? So radiotherapy, diagnostic imaging, nuclear medicine. The PACT program sits in a really nice space between the IAEA technical mandate and the UN focus on cancer. So together with IARC, with the WHO, and with IAEA technical staff, we conduct impact missions, so comprehensive cancer assessments. And I may see some of the countries in the room that have benefited from these joint assessments. And I think really to answer your question, Isabel, it's really that how do we align with the IRCC with looking at resilience? And it's really to understand the system and have those systems assessed and prepared and sustained so that during a crisis, the countries are able to continue services or be prepared for when the situation normalizes or minimizes a bit. Because resilience is really built before any shock. And we need to do this through evidence-based prioritization. And those impact reviews can provide the evidence base and help countries to prioritize within the cancer system what's important. So right now, we are working with Lebanon. Lebanon requested an impact mission. And we have decided through consultations with the Ministry of Health that we are going to continue to pursue the assessment. Right now, we're going to do it in a virtual situation where we can continue to engage with the experts in the country, the international experts that have committed to provide their support for the assessment. I met with the Ministry of Health this week during the World Health Assembly, but I will say that, you brought up COVID. We learned a lot during COVID. We did not want to stop providing these assessments to countries even when we had this global crisis. So we really adapted to a virtual modality. So there were countries like Benin and Burkina Faso where we continued to provide this expert support even during that COVID crisis so that we wouldn't lose ground, so that countries would be prepared again when the pandemic subsided where they could begin to implement these recommendations.
Okay, good. So Lisa started to mention about resilience, so maybe then I can come back to Dr. Rasha. Gulf CDC work really with these 6 countries across the region. And you mentioned that these countries are similar, but these countries are also actually very different. They're similar but different. So learning then from these 6 countries, what do you think really is a resilient health system?
Thanks. Maybe just to capitalize on the mandate of the Gulf CDC. So the Gulf CDC, I'm talking about the 6 countries in the region, which is the Kingdom of Saudi Arabia, Kingdom of Bahrain, the State of Kuwait, State of Qatar, the Sultanate of Oman, and the United Arab Emirates. So those are the countries that we are serving, and our mandate is to support the development of practices and collaboration of collaborative programs, and here comes the non-communicable diseases, for example, and also to enabling the collection, integration, and use of health data, enhance the preparedness and early detection, and promoting the training. So this is, again, among our core mandate. So how we see the resilience in the region, especially when it comes to the cancer system, it is one that maintain the essential cancer services during regional, for example, instability. So this include sustain the screening programs, the diagnosis, the treatment, the palliative care, and access to the oncology medicine. Also, during this recent conflict escalation, that shows us that cancer can be disrupted indirectly, not only through the damage to the health facilities, but also through the delayed, for example, the shipments, the restricted movements between the countries. And also this create a pressure on the health system. So a resilient system, therefore, really requires continuity of care on the cancer and the non-communicable diseases to be explicitly included in the emergency preparedness and the rapid risk assessment. And this really what we do in the Gulf CDC. So we have, for example, produced, for example, in the last period, this couple of months, we produced like 29 public health focused situation reports that assess the situation in the region. And this was including the health services continuity, the environmental risks, the logistics, the essential services, and medical supply chain. So the discussion, it was on the continuity of those services and to maintain them. Also, a resilient regional cancer system also requires a strong communication, and this is what we are trying to do, to communicate between our member states. And also we have tried to convene a roundtable meetings bi-weekly during that crisis. So this communication also enable us to utilize those facilities, for example, or the experiences between our member states. So this is, again, another strength for the Gulf CDC and how we can work. And finally, also the resilience, we are utilizing the periods of crisis also as opportunities to learn from it and to identify the gaps and build stronger and more responsive health systems. And this is really, as an example, one of the important lessons we identified during this last crisis. It was we identified that there was a need to strengthen, for example, the knowledge and awareness around the mental health, first aid and psychological support for the healthcare workers. And now we are developing a guideline to cover that area. So again, we are taking the opportunity from those challenges also to learn and to close some gaps which is raised in the region.
I think now we learn quite a lot about the a lot of tasks and mandates of the Gulf CDC. It's a really broad framework, yeah?
It is.
It's amazing.
Thank you.
So the other new mandate that Madame Amprou has recently taken over is really working much recently, I think this is some months ago, with the UN UNITAID. So UNITAID is really a specific, has a really specific position in the global health architecture, and we would love to hear it more about it. But when you see then crisis and cancer control, what are then some of the strategic priorities for UNITAIDs in this area of work?
Quand il y a des crises sanitaires, on teste la résilience d'un système de santé finalement avec une crise sanitaire. Et très souvent, quelle que soit la crise sanitaire, il y a des similitudes, des ruptures de chaînes d'approvisionnement, un accès aux services de soins qui est interrompu. Des professionnels de santé qui vont être... On va manquer de professionnels de santé. Et donc, il y a des similitudes. Et donc, quand il y a une crise sanitaire, finalement, on a besoin d'innover. Et l'innovation, c'est justement l'ADN d'United. United est une petite organisation qui se concentre sur l'accélération de l'innovation, mais ça ne s'arrête pas là, parce que l'innovation seule, ça ne sert à rien. L'innovation n'a du sens que si on donne un accès à l'innovation et que l'ensemble d'une population, soit sur une maladie, et notamment sur le cancer du col de l'utérus par exemple, on donne un accès. Et l'exemple d'United sur le sujet du cancer, ça concerne justement le cancer du col de l'utérus. Que fait United? United porte des innovations pour faire du dépistage précoce, ça veut dire mais ça veut dire aussi de donner un accès aux femmes au dépistage précoce dans des pays en développement, dans des régions plus reculées, à des femmes plus éloignées des services de soins, avec des nouvelles méthodes, de la formation des professionnels de santé. Une fois qu'il y a du dépistage précoce, quand il y a besoin, de pouvoir apporter des traitements avec des innovations. Et donc c'est comme ça quand dans certains pays, United intervient et dans des contextes de crise, avec de l'innovation, en s'appuyant sur les gouvernements, en s'appuyant sur les communautés, et avec l'ensemble des partenaires. United ne travaille pas seul, c'est tout petit United. Donc on travaille forcément avec des partenaires locaux. On va apporter une solution et on va contribuer à la résilience d'un système de santé qui ne se fait pas en un clic, la résilience d'un système de santé. La résilience d'un système de santé se construit dans la durée en anticipant, en innovant, en investissant.
Thank you. So now we heard a little bit about each of them, the institution that we are working with here. I want then to ask then the next few questions really then on the practical matters. So Lisa, again, you've worked really with a lot of different ministries, with a lot of different WHO region, and I'm sure that you've seen the whole full spectrum from very strong, resilient health system to then those that are much more fragile. From a practical point of view, IMPACT has these missions where then you work together, but then sometimes then you go on and then thinking of the implementation. Sometimes countries also say, oh, I don't want to do that, or I want to do this, right? So how does it look like actually the practical support that IAEA gives to country?
Oh, thank you, Isabel. So I think really if we think of it in a three-step process, so assess, stabilize, and sustain. So I talked about the assessments, these impact missions that are done, again, at the invitation of a Ministry of Health. So we only go if a ministry invites us in. And then we assemble the team of international experts and work closely with the experts on the ground for that assessment. So we want to, again, make sure that it's evidence-based prioritization and that there is that relationship and that interaction between the national focal team and the international expert teams. So really in a crisis, what you need to understand, what the country, what the Ministry of Health needs to understand is where the system is breaking and what must be protected. The impact review approach provides this structured situation analysis, again, prioritized recommendations, short, medium, and long term. And if a country is moving into a crisis or emerging from a crisis, you have those staged and staggered recommendations. So we have some examples from some very fragile countries, and we've been working with them throughout the years. So one example is from Afghanistan, where we were invited in 2019 to carry out the first ever assessment of the cancer care needs in the country. And it was really, they described it as the first step to understanding what the gaps were and what the needs. So these impact assessments can help countries to prioritize interventions that can be used as a basis to secure strategic funding. So even under severe constraints, and there have been changes even since 2018 when the impact mission was there, it still can provide a baseline. Those recommendations can be revisited even a decade later, and a country can determine what still remains a gap area, what is still a priority, what has changed, and then there can be a reassessment if that's appropriate. The second phase is really stabilize. So when we address this continuity of essential care services, these diagnostic pathways, so again, thinking about the core technical areas of IAEA, the diagnosis, which is key in a cancer system, the radiotherapy continuity, and the structural underpinnings of safe and secure delivery of radiotherapy, again, thinking about that in a crisis situation and what makes sense at the time. We also were invited into Syria to do an impact review, and that mission had been delayed. We started it in the virtual modality, and then we were able to go in and visit the country a couple of years ago, assess the cancer services nationwide, and it was really how can we stabilize some of the core functions in the country to be able to provide that basic cancer care, and while maintaining this quality, safety, and security because of the, within that context. And then the third point is sustainability. So that look at recovery and system strengthening. So the crisis response needs to ensure that there's the opportunity and the ability through these prioritized evidence-based recommendations to transition quickly into recovery and resilience building. So looking at that strategic plan, assessing the situation as it is now, and where does the country want to be? How do you follow up, and how do you bring partners around the table to, with this plan? And the last example in this area is Iraq. We were invited into Iraq, and again, we started the assessment in the virtual modality. The team was able to go in, and I was just so happy last week at the Cancer Planners Forum, which has been mentioned already, to see the representative from Iraq talking about the importance of that impact mission, how they're continuing to build relationships for training, again, to strengthen, how they want to expand their cancer services, and asking for a follow-up review, again, maybe in a virtual modality, to look at the progress that they've made. So I think, depending on where a country is, there are opportunities along that pathway.
Yep. So now, Lisa just mentioned about phases, resilience, sustainability. Coming back then to Russia, thinking of then, and priorities as well when we are talking about crisis, health system, but I'm sure not only within crisis, within a stable health system, we also then see there are needs for priorities. Cancer control and cancer continuum is a phase, has phases of its own. Crisis has phases as well when we're thinking of reacting towards crisis, when we're thinking of preparedness, continuity during crisis, recovery afterwards. Russia, in terms of then the work within Gulf CDC, is there any priorities area where then you think are especially neglected than if we're thinking about health system resilience and crisis?
Thank you for the question. So again, I think this idea of phases, it is also there. So like looking before any crisis is there, and during and after that. So again, the role of the Gulf CDC really, before it's just to provide this in preparedness time. So the preparedness that to ensure that the cancer is built into the emergency planning during the time that we need them. So we are making sure that all the countries, they have this preparedness plans, and also during any crisis or issues happening. So the enhancement of the monitoring and coordination posture to follow the potential public health implications that it's happening between in the region. And of course also the continuity supported in the coordination. And this coordination really, it builds upon what's the gaps between the countries. So if there is facing any gap in one country, we can also coordinate between the others. I will just give a small example during this last period of time. So there was a raised issue from one of the countries that was, there was a hit on their electricity supply. So there was a question raised, what about the home service patients? So we have some patients in home. We can just provide electricity in the hospitals, but what about those patients at homes? So really this brings us also to discuss how we can, on a regional level, to support something like that, to mobilize those services, the patients among our region and our 6 countries. So providing also a structured mechanism of exchanging the updates, identifying the preparedness gaps, and coordinating the regional needed support, it is again something that we can provide to the countries. And also we can support countries in assessing what was disrupted, such as the delay of the screening, the treatment interruptions, the medicine shortage, the services blockage, and then use the regional coordination mechanism to support these shared learning. And also we are now trying to compile all of these lessons learned we have, so what went well, with the support that the Gulf CDC provided, and what went wrong, and how we can develop and improve our role as a regional role to support the countries.
Thank you so much. One last question. So one last crisis that we haven't mentioned here is the climate change. Sometimes I'm quite happy with the climate change. I come from a warm country, and then when you're living through the winter in Lyon, you kind of then quite glad if then the winter is not so cold. But climate change is real. But often when we're talking with governments and so on, climate change is often put aside because climate change is diffuse. Climate change takes a long time, and government often then are more reluctant to work together in actions, in programs that may take a long time to take impact. Climate change is one of the key priority areas of UNITAID. So what do you think institutions around the world should be doing today to build a more climate resilience institutions on top of their health system?
Le changement climatique est vraiment transversal et touche toutes les institutions et en fait challenge la résilience des systèmes de santé. Et je pense que c'est un point important. Tout simplement, quand il y a un événement climatique, une population ne va plus avoir accès à des systèmes de soins, ne va plus avoir un dépistage précoce, par exemple, pour le cancer, mais un changement climatique va provoquer aussi des déplacements massifs de population, potentiellement, et va avoir un impact sur tous les déterminants sociaux de la santé, l'air, l'eau, la nourriture. Et donc, on voit bien l'ensemble de l'impact. Et donc, ça concerne, je dirais, toutes les institutions de santé mondiale, la santé animale, la santé humaine et la santé de l'environnement. Et c'est d'ailleurs pour ça qu'il y a tout juste un tout petit peu plus d'un mois, nous avions ici à Lyon le One Health Summit, justement pour aborder ces sujets-là. Dans cette perspective, UNITAID a développé une stratégie santé-climat. Avec une perspective propre à UNITAID, c'est-à-dire sur les sujets innovation et des produits de santé, en se posant des questions très pratico-pratiques pour UNITAID dans le cadre de son mandat. Puisque quand on regarde le changement climatique, il y a un changement climatique et santé, je dirais que ça marche dans les deux sens. Le changement climatique a un impact sur la santé par rapport à ce que je viens de dire, mais nos systèmes de santé ont un impact sur le changement climatique, potentiellement en l'accélérant. Et c'est dans ce sens-là qu'UNITAID a réfléchi en regardant, par exemple, le sujet des produits de santé. D'une part, dans un contexte de changement climatique, comment s'assurer qu'on garde un accès à un produit de santé dans de bonnes conditions et comment s'assurer que la production des produits de santé ne contribue pas à l'accélération du changement climatique. Et donc, on regarde certaines innovations sur des produits de santé, par exemple pour regarder s'il est stable à la chaleur, ou est-ce qu'il peut être conservé sans une chaîne de froid trop complexe. Sur du diagnostic précoce, est-ce qu'on peut avoir des diagnostics décentralisés en cas de choc climatique, par exemple grâce à des autotests pour éviter qu'une population ait à se déplacer si elle ne peut pas du fait d'un choc climatique. Et ensuite, en termes de chaîne d'approvisionnement, s'il y a un choc climatique, qu'est-ce que ça veut dire en termes d'innovation et s'assurer que la chaîne d'approvisionnement est assurée. Et c'est dans ce cadre-là que nous avons développé la stratégie santé-climat sur des sujets produits de santé, qui a d'ailleurs été présentée à la COP et qui fait l'objet de travaux de suivi et de mise en œuvre de manière très, très concrète. Donc je vous donne juste un exemple, qui est l'exemple d'United. Je pense que chaque institution doit se poser cette double question. Comment, dans mon mandat, j'apporte une réponse sur les sujets de santé lors d'un choc climatique et comment mon mandat et ce que je fais a potentiellement un impact d'accélération en termes de changement climatique et auquel cas essayer de changer certaines habitudes. C'est exactement ce qu'on a voulu faire et aussi parce que ce n'est pas d'un côté l'innovation, d'un côté une réponse au changement climatique, c'est totalement interdépendant et ça dépasse la santé humaine et on retombe sur l'approche une seule santé, la santé humaine, la santé animale et celle des écosystèmes.
One health. I think that's then that's where we're going to end. So we have 1 minute now just to end the session. I'll pose then the last question, and this question goes to all of you here in the, as participants. What can we do then now to support a more resilient cancer control? But then I'll ask then, well, then you're thinking about it and maybe you want to work with us in it, please email and let us know. But then for then each of the institutions here, just a very quick answer. What can IAEA, CDC Gulf and Unitaid with La France in general contribute and work together on this? Lisa, maybe first.
I think quickly I'll just say partnerships, because no one organization can do it alone. So it's partnering with countries, with ministries, and partnering with others in the region, in the country, and at the international level.
Partnership, that's first, Rasha.
So maybe again, what we have experienced in this rapid risk assessments, the emergency roundtables that we did, so maybe this is something that we can adopt a resilience tool to add guidelines to the Gulf CDC context, particularly around the continuity of the oncology services, the screening programs, cancer resilience, and the medicine access.
And finally, Madame Amprou.
Alors, le terme de partenariat a déjà été mentionné, malheureusement, mais je souscris totalement, d'une part, parce que seul, on ne peut rien faire. Et pour un système de santé résilient, seul n'a pas de sens. C'est vraiment des partenariats. Mais j'ajouterais interdépendance des acteurs, interdépendance des niveaux d'intervention global, international, régional, national et local. Et si on revient à la première question que vous m'avez posée en termes de parcours, c'est cette interdépendance sur laquelle je veux vraiment insister, parce que c'est vraiment une des solutions ou une des leçons à apprendre pour la résilience d'un système de santé en termes de partenariat avec l'ensemble des acteurs.
Very good. Thank you so much. Thank you so much all for being here, but partnership, I think that's the last word of the day. Let's all partner together to combat and to work on research, on cancer prevention. So IARC is here for that, and we're really looking forward to working more with all of you. Thank you.
Thank you very much. Thank you to our panelists. Isabel, thank you very much. Great insights on day 3 of this conference. Thank you very much. Thank you for your insights. I said at the very beginning of this conference that we were coming from all 4 corners of the globe, which is fantastic. And we do have a ministerial roundtable coming up in just a moment. We have special VIPs, ministers coming from far afield. But what we wanted to do was just to have a couple of video messages. Ministers who could not attend today from the Republic of Korea, the Minister of Health, Dr. Eun Kyung-jeong, a video message from him for this conference.
Hello, my name is Dr. Jung Eun-kyung, and I am the Minister of Health and Welfare of the Republic of Korea. When we face challenges to public health, everyone may have an opinion on what to do. But it can be difficult to identify the right course of action, and opinions alone do not make good policy. We must look to the evidence and base our decisions on the best available science. International collaborations such as the HELPER study conducted in partnership with IARC in my country are the source of this evidence. Thank you, IARC, for your work in preventing cancer these last 60 years. Happy birthday and many happy returns.
Great, warm round of applause, thank you very much. And we had somebody from Korea on one of the panels on the first day, so great to have that representation. Also a message now from the Minister of Health in Germany, Nina Wakin.
Excellencies, honorable guests, ladies and gentlemen, I would like to take this opportunity to extend my warmest congratulations on the 60th anniversary of the International Agency for Research on Cancer. Germany was one of the founding members when IARC was established on the 20th of May 1965. We have watched IARC grow and are delighted that many more countries have decided to join. IARC does outstanding scientific work that is critically important not only for global cancer prevention, it also provides guidance for our national health systems. For example, with the monograph series, critical recommendations on the cancer risk of new substances are published. IARC's scientific publications form the basis for national cancer prevention and control. Germany remains a steadfast supporter of IARC. Today, I am very pleased to announce that Germany will provide IARC with an additional 600,000 euros in funding. I wish you fruitful discussions in this session and a successful conference. Thank you.
Thank you very much. Also some good news there with the announcement of the funding, so that's always great to have that at the end of a conference, so thank you very much. Now we go to Egypt. The Minister of Health in Egypt, Dr. Khalid Abdel Ghaffar. A video message.
Excellencies, distinguished colleagues, esteemed partners, and public health leaders, it's a great privilege to address you today at the International Agency for Research on Cancer, an institution that represents scientific excellence and our collective commitment to advancing cancer control through evidence, innovation, collaboration, and equity. Egypt's journey in cancer control is not merely the story of a national program, it is a story of a national transformation. Transformation guided by Egypt Vision 2030, which places health, equity, innovation, and sustainability at the center of our national development agenda. Our partnership with the IARC reflects the core principle of Egypt Vision 2030, particularly the pillars of knowledge, innovation, and sustainable health care. We recognized early on that fragmented data could not sustain meaningful progress. Through our collaboration with the IARC, Egypt has made a decisive transition towards a nationally representative, globally comparable population-based cancer registry system. Together, we have aligned our cancer data system with international standard integrated screening, diagnosis, and treatment, and outcomes into a single comprehensive continuum of care and embedded reporting mechanisms within the healthcare system to ensure sustainability and accountability. This collaboration ensures that every person screened, diagnosed, and treated contributes to a broader national and global effort, one that informs evidence-based policymaking, strengthens cancer intelligence, and improves outcome for future generations. Since 2019, a screening program for 6 types of cancer has been ongoing under a presidential public health initiative, covering liver, breast, colorectal, lung, prostate, and cervical cancers. This program is one of Egypt's flagship public health initiatives and a true embodiment of Egypt's Vision 2030's commitment to social justice and universal health coverage. The achievements of this initiative has been transformative. Millions of visits and millions of people have benefited from that program. Hundreds of thousands were linked to care, and tens of thousands were diagnosed much earlier and timely linked to management. These outcomes clearly demonstrates that investing in people's health is not only a social responsibility, but also a strategic investment in sustainable development and economic resilience. Your Excellencies, in line with Egypt's vision, emphasis on digital transformation and innovation, Egypt is also advancing the deployment of teleradiology, digital pathology, and artificial intelligence to accelerate diagnosis and improve efficiency. What once took nearly a month can now be completed in less than 10 days. This transformation is not solely about technology, it's about improving patients' outcomes and addressing systems healthcare challenges, including shortages in specialized human resources, through innovative and sustainable solutions. These initiatives represent Egypt's vision in action, and under the health pillar, it advances universal health coverage and equitable access to quality services. Under the knowledge and innovation pillar, it's strengthening research, training, and national capacities. Under the economic development pillar, it enhances efficiency, reduces costs, and certainly supports sustainability. However, under the social justice pillar, it affirms women's health as a fundamental national priority and right. At the same time, our efforts strongly align with global framework, including the World Health Organization Global Breast Cancer Initiative and the WHO targets to reduce liver cancer-related mortalities and cervical cancer by 2030, demonstrating how national leadership and political commitment can accelerate global progress. Our collaboration with the IARC is only a beginning. Egypt remains fully committed to strengthening survival data and long-term outcome monitoring, expanding registry coverage and analytical capacities nationwide, and ensuring Egypt's experience as a scalable and replicable model for other countries. Because the true measures of success is not only what we achieve nationally, but also what we enable others to achieve globally. Ladies and gentlemen, behind every data set is a human life. Behind every percentage is a person, a family, and a future saved. Egypt's vision reminds us that health is the foundation of sustainable development. By protecting women's health, we protect the strength and future of our societies. Through our partnership with the IARC, we ensure that this protection extends beyond borders and contributes to the stronger global response to cancer. Our message today is clear. When political commitment is strong, partnerships are meaningful, and data systems are robust, transformation is not only possible, but also scalable, sustainable, and impactful. And I thank you.
Thank you very much, the Egyptian Minister of Health. Great to have the message there about the human connection. That's a conversation that I've been having over the past few days. The importance of making sure that that's a top priority when it comes to all of this. It's great to finish this conference with such a high-level roundtable. We've had these video messages from high officials. We also have ministers present here at the conference and senior officials from right around the world. And perhaps that's a strength when it comes to IARC, the cooperation and the voices from countries right across the globe. This session, this Ministerial Roundtable, is titled The Science Policy Interface for Global Change. And really, as we come to the end of this conference, it's looking forward, isn't it? It's taking a lot of the information, a lot of the talking points, and see how we can move forward. To moderate this session, I'd like to call onto the stage, please, now, Dr. Elizabeth Vitapas, Director at IARC, onto the stage. A warm welcome. Thank you very much. Elizabeth, thank you very much. I'm also going to call all of the panelists onto the stage as well. From France, we have the Deputy Minister of the Ministry of Health here in France, Camille Gallia-Minier, as well onto the stage. A warm round of applause representing France. Here we are. Thank you very much. Great to see you. And also, just a reminder, and if you wanted to take your seat at the far end, that's great. Don't forget, we are going to be having some translations available. So if you have your headphone, if we are speaking in French, you have a translation into English. Also with us from Brazil, the Minister of Health from Brazil, Dr. Alexandre Padilla. A warm round of applause, please. Thank you very much. Also from Morocco, the Minister of Health from Morocco, Amin Tarawi. A warm round of applause representing Morocco here for this last roundtable. Thank you very much. Welcome. And from Indonesia, from the Ministry of Health, we have the pleasure of calling on Budi Gunadi Sadikin. Sorry for the pronunciation, it's very difficult, isn't it? Oh, it's 100% correct. Thank you very much. I get 10 brownie points for that. Thank you very much. Also from Saudi Arabia, from the Saudi Arabia Health Council, I'd like to welcome Naha M.L. Azemi. Welcome. Thank you very much. Great to see you. And also, not far from where I was born, Australia. I'm half New Zealand, half Irish. It's a pleasure to welcome from Australia, Blair Comley. Oops, thank you very much. The Secretary at the Department of Health in Australia. So when I say all four corners of the world, it absolutely is that. We were also hoping to have with us also Dr. Jeremy Farah, the Assistant Director General Health Promotion, Disease Prevention, and also Control from the WHO, but that was supposed to be online, but difficulties connecting with the Wi-Fi, apparently. So great. Over to you, Dr. Elizabeth, for this roundtable. Thank you very much.
Thank you very much. Distinguished ministers, esteemed colleagues, and honored guests, it's a privilege to welcome you to this Ministerial Roundtable discussion. In opening this session, I would like to frame our conversation around a simple proposition. Cancer research delivers value when it helps countries make better decisions for their populations. This afternoon, I invite you to focus on the practical conditions under which evidence becomes impact. Stronger prevention strategies, more effective screening programs, earlier diagnosis, better organized care pathways, and improving monitor of outcomes and inequalities. While implementation is national, no country acts in isolation. International scientific cooperation is essential to provide robust data, common standards, evaluation tools, and comparative experience that allow ministries of health to move faster and with greater confidence. This discussion will highlight real-world examples on how research has shaped national cancer strategies. I invite you to share your experience, discuss challenges encountered, and reflect on how science and policy can work even more closely in the years ahead. Together, we can ensure that cancer research continues to translate into action for the benefit of patients, communities, and future generations. Let's start with Madame Gaia Minier. With a new law approved in June 2025, France has created a national coordinated cancer registry. Can you please explain how, thanks to this new legal framework, France will better integrate its cancer registries across regions and care settings to ensure decision makers have timely, high-quality information for planning and improving cancer services, and why this is so important. And Madame will express herself in French, and if you need translation, please use your devices. Madame, please.
Merci Madame le Président pour cette question. Tout d'abord, je suis évidemment très heureuse d'intervenir dans le cadre de ce 60e anniversaire du Centre international de recherche sur le cancer. Le cirque qui est fort de ces 300 scientifiques de toutes nationalités, c'est finalement vous incarner et incarne ce que la mobilisation finalement internationale peut faire de mieux, et puis permet de rappeler à tous et à toutes l'importance du message selon lequel les politiques publiques de santé en fait doivent s'appuyer s'appuyer sur des données scientifiques pour être efficace. Alors, en répondant à votre question, effectivement, pendant longtemps, nous avons principalement évalué les politiques du cancer avec deux critères, que sont à la fois deux indicateurs, que sont l'incidence et la mortalité. Ces deux éléments sont évidemment essentiels, mais aujourd'hui, on sait qu'ils ne suffisent plus et qu'il convient de mesurer la capacité réelle des systèmes de santé, à la fois de réduire les inégalités, de détecter plus précocement les cancers et puis surtout de mieux orienter les politiques publiques. Et c'est finalement exactement dans cet esprit que la France a lancé le 1er janvier 2026 un registre national du cancer, et ce registre constitue finalement une avancée majeure pour notre système. Il va pouvoir à la fois améliorer le suivi épidémiologique, mieux mesurer les parcours des patients, évaluer l'efficacité réelle des politiques de prévention et surtout renforcer aussi le chaînage des données de santé à l'échelle nationale et internationale. Et c'est un outil qui va nous permettre de mieux comprendre également les liens entre l'environnement et la santé, les maladies et le cancer, et c'est exactement dans le prolongement de One Health. Concrètement, il y a 3 indicateurs qui nous paraissent vraiment prioritaires, à la fois la participation au dépistage organisé, notamment pour les populations les plus éloignées, le stade au diagnostic, parce qu'un cancer finalement détecté tôt se soigne mieux, et enfin la mortalité évitable. Et ces données, surtout, doivent nous permettre à la fois d'agir plus vite, de cibler les politiques publiques et de réduire concrètement les pertes de chance de nos patients.
Merci, Madame la Ministre. My next question goes to Dr. Alexandre Padilha. Brazil has recently strengthened its national cancer policy and service network. As implementation moves forward, where should the next priority be? On making navigation work at scale, modernizing screening pathways, or improving interoperability of data systems across the national unified healthcare system, or something else? Minister, please.
Thank you, Dr. Elizabeth. Thank you, Madame Galliard, my colleagues, ministers and secretaries, distinguished participants. Before answering your question, I say the importance to be in a conference like that, research conference, and the importance, the priority that research, good research, it's a round table, very important for policy decision. Because we are facing a civilizatory war, a war in which all those who defend life must be engaged. Trust in evidence is challenged, and science is too often denied. This conference is so important because it reaffirms that independent, transparent, and publicly accountable science is the most important, reliable foundation for health policy decisions. We all know the cost of neglecting science. That's why, first of all, Dr. Elizabeth, as I told recently to Dr. Tedros, WHO, the whole WHO United Nations system may count with my President Lula's support. Even to survive the recent attacks from some countries that are reducing financial contributions. We'd like to announce that my government authorized the Brazilian National Institute of Cancer to make an extraordinary contribution to IARC to help to maintain your quality standards and sustainability that the challenges are facing. My country faced the impact when negationism dictated political decisions. More than 700,000 deaths during the pandemic in my country. A severe backlog of surgeries, delayed exams, and a repressed demand that our health system still feels today. But Brazil has re-entered a route of civility. President Lula da Silva stated as a mission, build the largest public, universal health facilities network in the world to prevent diagnosis and care cancer. Last week, in his presence, We established new public financing mechanisms to expand breast reconstruction after mastectomy and to incorporate oncological robotic surgery, as well as 26 new chemotherapy schemes to the Brazilian universal free public health system. This decision will guarantee universal access to cutting-edge treatment and technology to everyone that needs. From our perspective, innovation without access should not be called as innovation. Innovation without free access is injustice. That's the word that it should be called. We are transforming reality through the Agora Tem Especialistas, our national program to enhance specialized care access, providing specialized medical doctors, connecting specialized care with primary care, real-time monitoring, and pursuing reduction of waiting lists. For cancer, time is life. We expand and updated screening programs, settled Diagnosis National Center to reduce the time to the results of pathological examination from an average of 8 months in remote areas to less than a week. We are also executing the world's largest purchase of linear accelerator, more than 155 new equipments. New financing mechanisms to encourage performance and capacity. Monitoring of radiotherapy centers are also established. We are also expanding radiological image equipment to provide faster diagnosis and treatment follow-up. The pathological diagnosis is part of the digital health transformation that we initiated, that we begin in Brazil, in my country. Interacting with your question, Elizabeth, I would say that it helps to achieve what I think it's the most important next step, to scale up patient navigation work. The key points of your questions are linked. We will only achieve this goal if we improve interoperability of data systems across SUS, our national health system. The use of artificial intelligence will identify early warning signs, ensuring a continuous human-centered patient journey, while data interoperability guarantees that a universal system like SUS speaks the same language. We've already achieved good results. We reached to 340 accredited oncology centers nationwide. In 2025 compared to 2022, our national public health system has increased in 40% the number of oncological surgeries, in 30% diagnosis exams, 22% radiotherapy procedures, and 20 chemotherapy treatments. Thank you.
Thank you. Thank you, Minister Padilla. I cannot say how proud I am of hearing this progress and the priority that the government Lula has put on cancer and all the progress made in the last year. So congratulations. And from all IARC community, I thank you for the generosity of your government in supporting science and supporting IARC. Thank you very much. My next question goes to Minister Amin Tehawi. Morocco is also investing in long-term research infrastructure, including registers and biobanking. From a health minister perspective, how do you decide when these become not just research assets, but essential tools for better planning, equity monitoring, and quality of care?
Thank you very much. As we are in France, in this beautiful city of Lyon, please allow me to continue in French language.
Yes, please.
Tout d'abord, je voudrais remercier le cirque pour cette invitation. 60 ans, c'est le temps long de la science et c'est aussi celui de notre partenariat avec le Maroc. Le Maroc n'est membre du cirque depuis 2015, mais ce partenariat porte déjà des fruits concrets pour nos populations avec un bénéfice certain et c'est dans cet esprit-là que je suis ici aujourd'hui. Alors sur la question de l'investissement des registres et des biobanques, en 2010, lorsque nous avons construit notre premier plan national cancer, nous n'avions pas de données marocaines fiables sur l'épidémiologie du cancer et nous avons donc réalisé plus de 15 études nationales. Et ce n'est qu'à partir de là que nous avons pu décider où construire les centres d'oncologie, quels cancers prioriser et quels territoires étaient les plus défavorisés. Alors cette expérience, elle nous a permis, elle nous a convaincus plutôt d'une chose, c'est qu'un registre du cancer, finalement, n'est pas un outil de recherche, c'est plutôt un outil de décision, de gouvernance, de mise en place de politiques de santé publique, parce que finalement, il vous dit où sont vos ressources, si elles produisent des résultats avec des indicateurs et surtout où les inégalités persistent malgré les investissements. Donc aujourd'hui, nous allons plus loin, nous développons des capacités de diagnostic moléculaire, nous préparons une initiative nationale de biobanque. Et pourquoi? Parce que finalement les données marocaines et de manière plus large les données africaines sont encore dramatiquement sous-représentées dans la recherche internationale et cela a des conséquences directes. Les thérapies développées sans nos données ne sont pas nécessairement calibrées pour nos populations. Et ça, c'est un véritable enjeu pour le futur. Donc aujourd'hui, en conclusion, pour répondre à cette question, je dirais que le Maroc ne veut pas seulement être un terrain d'application de l'innovation mondiale, mais voudrait en être un contributeur. Et c'est le sens des investissements que nous opérons aujourd'hui. Je vous remercie.
Merci. Merci, Monsieur le Ministre, pour ces clarifications. My next question goes to Minister Budi Gunadi Sadikin. As Indonesia strengthens its cancer registry and research systems, what should success look like by the end of this decade? A better national coverage, better data linkage, or stronger use of registry data to shape investment and service planning, or something else? Minister, please.
First, I would like to say happy anniversary, IARC. Cancer is very personal to me because my father died 20 years ago of multiple myeloma when he was 84 years old. My mother died just 1 week before my father because lung cancer. My father-in-law died about 15 years ago because of prostate cancer. And my mother-in-law died 40 years ago, even I haven't got the chance to see her, with breast cancer. So cancer became very personal to me. So when I became the health minister in 2020, at the end of 2020, very busy handling COVID, I just started become the true health minister in 2023. Now I look into cancer. I just realized that Indonesia doesn't have the National Cancer Control Plan. So with the help of IARC, IAEA, and also WHO, for the first time, Indonesia had our National Cancer Control Plan in 2024. Our registry compared to our friends here is far behind. We have a cancer registry, but not up to the standard. And even until now, I'm still struggling to put Indonesia on the CI5 latest volume. So I gave a task to my team with the help of Elizabeth. This volume, Indonesia should have at least 1 city. And every 5 years, we have to add additional 10 cities, put into the CI5 volume. And to do that, for the first time, I came to this magnificent location a month ago. I heard about IARC, I'd never seen IARC, and never met with Elizabeth. So last month, I came to IARC. And I didn't see Indonesian flag. And I know Iraq is a member of WHO. Why my flag is not here? I only see the French flag, the Brazilian flag, Saudi flag, the Moroccan, Australian, but my flag is not here. Because you are not a member of IARC. So because I know that I have a lot to catch up with my friends here, we have decided that this year our flag will rise. Indonesia will become the member of IARC. And although we are not as rich as our Brazilian friends, we will pay our dues. So, ladies and gentlemen, we know we have a lot to catch up. That's why we have to work hard. Cancer kills 240,000 Indonesians registered. I believe the numbers are more. Number 1 is breast cancer, number 2 is cervical cancer, number 3 is lung cancer, number 4 is colorectal. So we have, and to handle cancer, I learned from Elizabeth, you need to diagnose early and you need to treat early. So screening is very important. Screening is very important. Last year, Indonesia embarked a very aggressive screening program to 280 million Indonesians. Last year we reached 70 million. This year our target is 136 million. For breast cancer, we distributed 10,000 ultrasound at 10,000 primary healthcare clinics in 10,000 districts. So Indonesia have one country, 34 provinces, 514 cities, 10,000 districts in 85,000 villages across 7,000 inhabited islands that serve 280 million people of Indonesia. So we deploy 10,000 ultrasound to do screening of potential breast cancer. If you identify as potential breast cancer, with the help of World Bank, we borrow $4 billion loan to deploy 514 mammogram in 514 cities to be able to do mammography, because breast cancer is #1 killer. When I joined, out of 514 cities in Indonesia, only 80 cities have mammogram facilities. You know, to make it more advanced, we decided to buy 16 PET scan deployed across the country in 16 provinces. For your information, December 2022, Indonesia, large country, 280 million people, 7,000 islands, we only have one city with 2 PET scans in Jakarta. So can you imagine the problem just to do a proper cancer screening? Now we increase that to 10, we will have 16 by the end of 2027. On top of breast cancer, cervical cancer, Indonesia is behind. We just launched our national HPV immunization program in 2023. We know we are behind. We know we are not as rich as our neighbors here. So that's why, with the help of IARC, we had made the decision by 2025, we reduce from 2 doses to 1 dose. So we accelerate. We finished the 11 and 12-year cohort. Last year we start with 15 and 16 catch-up program. This year we start with another catch-up program for women 20 to 31. And next year we will start with the boys on immunizations. We started last year to deploy HPV DNA testing as a standard. And then with the help of St. Jude, and also there is a famous hospital, I'm sorry I forget the name of the hospital, MD Anderson, somebody over here said, we deploy in our Puskesmas 10,000 thermal ablation technique, tools. So we can do thermal ablations for the HPV cancer. Because this cervical cancer kills 35,000 Indonesian women. So if we can accelerate the vaccination to finish in 20 years to 10 years, you understand that we can save 200,000 unnecessary deaths of Indonesian women. For lung cancer is the most difficult part. Before, when I joined, we only have 200 cities with CT scans. Now we already decided that we bought the CT scan, bid is there, World Bank money, and we start deploying. We will finish the 514 cities deployment in CT scan by 2027. I still came to IARC, went to one of the seminar room, because I know CT scan, to do low-dose CT scan for lung cancer is difficult. So I'm still looking if there is any other screening tool which is easier to screen at 10,000 Puskesmas, primary care clinics, to do lung cancer. Because this is #1 killer for Indonesian men. For colonoscopy, we also have issued a bid, and the colonoscopy has been deployed into 514 cities. I just heard this afternoon from Elizabeth, Because colonoscopy, like low-dose CT scan, is difficult. We have hundreds of millions of people. We cannot send them to do screening in the hospitals. Elizabeth told me, why don't you learn from Brazil? Because they did what called FIT, the fecal whatever blood testing, that which is cheaper to do and faster. So instead of doing it at 514 cities, we will do it in 10,000 puskesmas. So ladies and gentlemen, what I would like to share with you is, for somebody that behind, we have to have more energy and passion to catch up with our friends. Because every minute, every second we work faster, it will save life. And we realize that we are lucky because with the research and innovation, we can leapfrog because we don't have to reinvent the wheel. We don't have to go to a most difficult pathway or more expensive pathway. We can go directly to the cheaper one as long as my friend here would give it for me for free without paying any intellectual property expenses. Thank you.
Thank you. Thank you, Minister Budi. It's so interesting to think that Indonesia is about the same population size as Brazil, and the realities are so different, in particular because the island state of Indonesia, so many islands, so extremely challenged to reach the population in remote areas. But I think the South-South collaboration, as you mentioned, is also one of the priority areas that we definitely need to incorporate together, of course, with Morocco and other countries. My next question goes to Dr. Nahar El-Azimi. Saudi Arabia is aligning cancer control with a broader prevention and healthy lifespan agenda. In that context, what should be the next priority for measurable impact? Organized screening or stronger surveillance? Or maybe reducing the metabolic and lifestyle risks driving future burden of cancer, or something else? Please, sir.
Thank you very much, Dr. Elizabeth, and thank you for the invitation to celebrate the 60th anniversary of IARC. And I really want to congratulate you and the IARC team and all the member countries for the achievements really over the last 6 decades. We can see this, the impact of IARC, internationally, and we can, for example, in our Saudi Cancer Registry, we really received a great help from IARC in building the registry, which is now we are going to celebrate the 34th anniversary for our registry, which was established in 1992. And talking about the priorities, in fact, cancer control in Saudi Arabia is coming integrated with the broader vision of 2030. In 2016, the Crown Prince Mohammed launched the Vision 2030 with multiple programs in all aspects with 3 pillars to have a thriving economy, ambitious nation, and vibrant society. And one of the main focus was a healthy lifespan. For that, the Health Transformation Program was created in 2019, and with 4 objectives or goals. To improve the access to care, to improve the value of the care, and also to emphasize the prevention through population health approach, and also specifically to target the road traffic accident and its impact on health system. So since 2016, a lot of achievements has been done. Now we are 10 years from the launch of the vision, and we see a significant reduction in road traffic accident. Also, and one of the objectives is the life expectancy. When we started, it was 77 years. Today, the target in 2030 is 80 years, and today we are 79.7. So we are, close to achieving this objective. And regarding the priorities, in fact, we don't see these as competing priorities. I think we need all of these: organized screening, surveillance, early detection. All of them are definitely necessary, and any health system, if we didn't intervene early, especially in the detection and the screening, we will pay a big cost. The cost of management will be higher, and the impact on whether it's on the social or psychological or the physical impact on the patient and the population will definitely be high. So this is why in Saudi Arabia, part of this vision, we focus on the prevention and screening, and through our cancer registry, we started to observe significant improvement in the early detection of breast cancer, for example. Almost 70% of the ladies, they come early, and we managed to improve the mortality rate and the cure rate. So I think those challenges we are facing, it's not only coming through these options, but also we have to treat the underlying cause. Like all the other, we have a challenge of obesity, challenge of smoking, and also inactivity, lifestyle, also the dietary causes of cancer. So for this, a lot of education campaigns are now active in the school and in different aspects. So in answering your question, I think through a comprehensive approach to a health in the general wide definition, we can work on cancer control and have a better outcome to our population. Thank you.
Thank you. Thank you very much, Dr. Al-Zeni. My next question goes to Dr. Cumley. How is evidence applied in the Australian context to population-based cancer screening programs, including design, eligibility, and implementation?
Thank you very much, Elizabeth, and congratulations on your 60th year. That means you're in what should be the healthy ageing stage, and I hope that you've already for 10 years been doing sit to stand and other strengthening exercises so that you can really be a good organisation again at 80. The other thing, before we get into the evidence, that I've been inspired by today being at IARC is the number of conversations about eliminating some cancers from being practical health concerns. And I think if you said that to most of the general public, that was a realistic ambition, they would stop and think very carefully, because of the example of people like the family of Pakbudi when they think about the impact of cancer on their lives. When we think about the evidence that we bring to our approach to public policy, I think the screening programs are a classic example of that evidence-based approach. We're asking questions through our national screening program, a framework where we say, will a screening program deliver more benefit than harm? Is it supported by strong scientific evidence? Does it represent an effective and ethical use of public resources? And is it designed to be equitable and nationally consistent? They're the questions that we ask. And that involves all those questions of, can I screen? How cost effective is the screening? Once I screen for it, have I got a therapy that's going to work? Or am I just finding out something that I can't do anything about? And I think the fact that we are close to practical elimination of cervical cancer as a concern in Australia is part of those questions. One, well, we can do vaccination first, which is fantastic. Second, we can screen for it, and then we have practical interventions if we catch it early enough. And so that's the framework we would bring across the thing. And I think this is actually, I'm a Secretary of the Department of Health, so cancer is one thing I worry about, but I worry about a lot of things. It's very, very similar to the way that we would approach our health technology assessment across the whole of the Australian situation. We think about drugs and therapies. What is the value of that intervention? I thought I might briefly touch on the National Lung Cancer Program, because that's our latest. So we've had breast and bowel and cervical screening, cancer screening for some times. National Lung Cancer Screening, we're only 1 year in. This was an evidence-based framework. It targets a cancer that's the 5th most common cancer and leading cause of cancer death in Australia. It is estimated there are more than 15,000 new cases and nearly 9,000 deaths from lung cancer in Australia in 2024. The program focuses on high-risk asymptomatic people aged 50 to 70 with a history of smoking, applies a risk-based population-wide screening approach. International evidence underpins the program's importance, showing up to 70% of lung cancers are detected at early stages by low-dose CT scans, and deaths are reduced by 20%. Obviously, like every other cancers, the earlier it is detected, the treatment is better. Opening a free program for people who are asymptomatic and at first at risk means we can catch the disease in more people sooner. The program is especially important for First Nation communities which carry a much higher burden of lung cancer. Now, we've made huge progress on smoking rates in First Nations communities, but they're still significantly higher than the general population, and there are other social determinants of health in First Nations, including remoteness, that make it genuinely challenging. But we're making a huge effort, and one of the things that we did when setting up the program is buy some mobile screening vans so that they could get out to where the people are rather than requiring them to come to the hospitals. So I think there's a very common thread through Australian health policy, which is we use the evidence from experts, we think what that means for the right interventions, including screening, but then we think about the practical design so that it can go to people in the field. Because really, high-level policy means nothing unless it changes the experience on the ground, and in this case gets the right people having the right screening at the right time to allow the earliest intervention possible. Thank you.
Thank you. Thank you very much. I mean, for us in the screening research field, we always look at Australia and how well Australia is doing in many fields, and particularly on cervical cancer elimination is a fantastic example to humankind. So congratulations for what you have achieved so far. It's really very inspiring for all of us. My next question goes for Madame Gallia-Minier. France has made prevention a central pillar of its cancer strategy. Given the evidence that a large share of cancers remain preventable, what should now be the next big implementation step? Stronger action on commercial determinants of health, such as alcohol and diet, or more targeted screening outreach, or sharper use of exposure data to reduce environmental and occupational exposures, or something else? What's your taking?
Merci beaucoup pour cette question. Effectivement, ce sujet de la prévention a été abordé par nombreux homologues qui sont présents aujourd'hui. Vous avez raison, finalement, la question aujourd'hui n'est plus de savoir si la prévention fonctionne. On sait qu'elle fonctionne, par contre, la question est de savoir comment on peut accélérer. Pour la France, la priorité finalement est désormais de passer d'une logique finalement d'information des individus, qui est déjà le cas, à une logique finalement de transformation des environnements de vie. En France, nous avons fait le choix d'une stratégie qui soit très concrète, qui est à la fois d'agir plus tôt, de dépister plus tôt, et puis de réduire les expositions évitables tout au long de la vie. Par exemple, concrètement, notre gouvernement, comme le gouvernement l'a annoncé, nous avons un objectif, ça vient d'être évoqué sur le cancer du poumon, de généralisation finalement du dépistage organisé du cancer des poumons, parce qu'on le sait, et ça a été répété, ce cancer des poumons est l'un des plus dangereux, des plus meurtriers, et on sait qu'un diagnostic précoce peut sauver de très nombreuses vies. Donc ce dépistage généralisé, il va avoir pour objectif effectivement de gagner en chance de vie, et ça se fait, ça s'appuie sur un programme européen, qui est le programme Impulsion, qui est un grand programme européen qui est consacré précisément au dépistage organisé du cancer des poumons. Et donc là, c'est un changement véritablement majeur de paradigme. Et la France est l'un des premiers à se saisir de ce programme. Et donc, c'est un des pionniers sur ce sujet. Et ce programme, il illustre finalement la manière dont nous voulons aujourd'hui construire les politiques publiques de demain, qui est à la fois articuler la prévention, dépistage précoce et réduire les risques. Et cibler aussi les populations finalement les plus exposées, tout en utilisant des données de santé, comme on l'a rappelé tout à l'heure avec le registre du cancer, pour mieux identifier les populations à risque. Bien sûr, nous devons finalement continuer à agir très fortement sur les grands facteurs évitables que l'on connaît, le tabac, le tabac, l'alcool, l'alimentation et puis les expositions, certaines expositions à la fois environnementales et professionnelles. Sur le tabac, nous avons des grandes campagnes de sensibilisation et aussi de développement d'outils d'aide, comme des sites Alcom Info Service. Et puis sur le tabac, nous avons évidemment des plans de lutte et de plans de lutte contre le tabac qui mobilisent évidemment l'ensemble des acteurs sur ce sujet. Et sur la nutrition, un grand plan nutrition santé pour l'alimentation. Et puis il y a des travaux de l'INSES et de l'HAS qui sont également en cours sur les expositions environnementales et professionnelles. Et c'est précisément aussi ce qui permet aujourd'hui et ce qui va permettre l'accélération, c'est la coopération avec le cirque encore pour de très nombreuses années, et j'espère aussi pour venir fêter ici le 70e anniversaire du cirque.
Merci, Madame. And thank you for all the tremendous support that France has given to IARC from day one. And if we are in this magnificent building that we occupy today, which is very appropriate for our research, is because of the generosity of the French public and the French government. So thank you from all of us from IARC. Many thanks. My next question goes to Minister Padilha. Brazil has already used international evidence to support major shifts such as single-dose HPV vaccination and HPV-based screening. What's the next prevention or early detection decision that most needs the same combination of modeling, real-world evidence, and implementation support in your point of view?
Thank you, Elizabeth. First of all, the international evidence provided or supported by IARC is so important for us. Thank you, the IARC production. We believe that major public health transformation become possible when science, political commitment, and strong public systems move together. As you mentioned, that was the case with single-dose HPV vaccination, and now it is transition toward HPV-based screening. As we like to state, eliminating cervical cancer is not only a health goal, it's a commitment to dignity, equity, and human rights. Australia is our goal. We'll reach to you. President Lula always says that no woman should fear a preventable disease. During the last 3 years, we will resuscitate our national vaccination program. HPV coverage among girls from 9 to 14 years jumped from less than 80% in 2022 to more than 90% in the end of 2025, and nowadays it's 5 times more than the world average. Among boys, it jumped from 67% to more than 80%. We expanded free universal offer up to 19 years old for both. We started national implementation of PCR HPV DNA screening, and we will reach every Brazilian state by the end of 2026. Both technologies nowadays are 100% Brazilian production by 2 of our major public labs, Instituto Butantan for HPV vaccine and Fiocruz for PCR testing. That means innovation, access, and sovereignty. We must work hard to eliminate cervical cancer in the next years in Brazil. To achieve that, Brazil is prioritizing the Amazon regions with the highest disease burden, while incorporating innovative approaches such as self-collections for indigenous people and remote population. As an example of a next step, I'm announcing today, during this conference, the national implementation of the first colon rectal cancer screening guidelines in our national public health system. Based on research, evidence, we start an early detection strategy for asymptomatic women and men aged 50 to 75 years at average risk, based in primary care, fecal examination, with the support of specialized image and colonoscopy centers when needed. I was kidding with my friend that as soon as we finished this panel, I go outside, I saw a map where Brazil is not painted, is not blue painted, because we do not have a national screening colorectal program. So I start painting the map there. And the next year, I will see the Indonesian flag and Brazil painted, blue painted, because we will have a national screening colorectal screening program. Thank you.
That's wonderful, Minister Padilla. So colorectal cancer then is the next target. My next question goes to Minister Tehauri from Morocco. Morocco has generated important evidence on breast and cervical cancer pathways. How can that evidence now be used to move from program improvement to more standardized national delivery, especially in reducing delays and improving quality across regions in Morocco? Thank you very much.
Merci pour cette question sur le cancer du sein et le cancer du col de l'utérus. Nous avons accompli quelque chose d'important. Nous avons structuré un programme national organisé qui a été intégré dans les soins primaires et accessible sur l'ensemble du territoire. Nous disposons au Maroc d'un peu plus de 3000 centres de soins primaires qui nous permettent aujourd'hui d'être très proches de la population et d'y installer des programmes de prévention, des programmes de vaccination, mais aussi la prise en charge précoce, la détection précoce et surtout la régulation et l'orientation vers les centres hospitaliers les plus appropriés en fonction des pathologies. Mais les données que nous avons accumulées par ailleurs, et notamment avec le partenariat de l'IARC, nous ont montré un problème particulièrement précis qui est celui des délais. Alors, le problème des délais, et c'est ce qui tue malheureusement beaucoup de femmes aujourd'hui au Maroc, ce n'est plus le manque d'accès. L'accès peut exister, mais les délais entre le dépistage et le diagnostic, le délai entre le diagnostic et le traitement, ce sont ces ruptures, ce sont les ruptures dans les parcours, ce sont les femmes qui sont perdues de vue entre deux étapes du système ou deux étapes de prise en charge qui nous génèrent des résultats qui ne sont pas bons. Notre deuxième plan cancer 2020-2029 répond directement à cela. Nous avons travaillé et nous travaillons sur la standardisation des protocoles et sur les délais cibles dans toutes les régions. Et nous renforçons également les systèmes d'information pour suivre les parcours en temps réel. La digitalisation est un véritable levier qui nous permet d'agir là où, avec les méthodes traditionnelles, nous ne pouvons pas le faire, qui nous permet de suivre en temps réel le suivi des patients, mais qui nous permettent aussi de constituer suffisamment de data que nous pouvons exploiter dans le futur, administrer et l'injecter dans la recherche pour davantage améliorer les traitements. Donc nous investissons aujourd'hui dans ces systèmes d'information, mais nous investissons également dans les capacités humaines, parce qu'un programme national ne vaut que si les moyens humains et techniques sont équilibrés sur les terrains. Sur un pays comme le Maroc, c'est un véritable enjeu territorial. Nous avons des régions qui sont reculées, nous avons des régions qui sont difficiles d'accès, nous avons des régions qui sont moins avancées que d'autres, dans lesquelles ces investissements sont un levier majeur d'amélioration. Et finalement, ce que l'expérience marocaine, je pense, démontre, c'est qu'un pays à revenu intermédiaire peut aujourd'hui construire une politique cancérologique nationale et qui est fondée sur ses propres données, sur ses propres contraintes, sur sa propre géographie, avec des résultats qui sont mesurables. Et évidemment, nous voulons partager ce modèle avec nos partenaires africains, et pas seulement, pas comme une leçon, mais plutôt comme une base de travail commun. Et pour mon ami indonésien, c'est évidemment totalement gratuit.
Thank you. Thank you, Minister. And I mean, the challenges has been identified, and now it's very reassuring that you are working towards decreasing the delay between the screening and treatment. My next question goes to Dr. Budi Gunadi Sadikin. Minister, Indonesia is expanding breast and cervical cancer efforts at scale. What will be the most important for moving from promising pilot studies to national impact? Stronger quality assurance, better program monitoring, or more locally generated evidence that works in primary care?
Like my Australian friends mentioned, Budi, when you do a lot of screening, you'll find more people with cancer diseases. Your next problem is how to treat them. And that created another big issues in Indonesia. So after all the screening, we realized that in breast cancer, I believe also in lung cancer, in colorectal, you need to do biopsy after screening. Biopsy, we do have the skill in the 5 metropolitan cities. The biggest issue with us is the pathology lab.
Yeah.
Because we only have, if I remember when I started in January 2023, 100 out of 540 cities, so only 20% of my cities have the low-tech histopathology labs. I heard that, okay, there is a new technology, and I've seen it recently in first floor in IARC, is the immunohistochemistry lab. So because we have money from the loan from the World Bank, we decided to do the bid, and by 2037 we will have 514 immunohistochemistry lab, and we will equip at the provincial level 34 next generation sequencing lab. But the problem that I only have around 40 pathologists. And to produce pathologists is not as fast as to get the immunohistochemistry machines or next generation sequencing machines. So that creates another issues because the education system in Indonesia is so small in producing the pathology and database. There is a technology called a slide scanner that you can do digitally and do it. We are doing it, but still I realized that this is the first time I hit the problem on the human resources. And then if you do that, then we need to do chemotherapy as a basic therapies. Again, in Indonesia, less than 100 cities, can you imagine 20% of our cities only have the chemotherapy facility. I was being informed you need a device called cytotoxic drug cabinet. We had the money, we signed the contract, 2027 will be 514 cities. Then I realized we don't have enough medical oncologists. Medical oncologists even is as rare as pathologists. So then I'm struggling also, how can I increase the number of medical oncologists? I'm still scratching my head because the machine is coming in, but now not the medical oncologist. If I can import from Brazil, I will import from Brazil because I know they will need also the medical oncologists even in Australia. So that is also the problem that I have to reform the education system in Indonesia for specialists. And after medical oncologists, I know that the most complex treatment is the radiotherapy, the most expensive. Yeah. I will not put it in the cities because it's too expensive. So I put it in provinces, 34 provinces, 5 have Linacs. I bought 34 Linacs. And because at the provincial level, to educate, if I'm not mistaken, radio-oncologists, this one we can do, 34. Yeah, because we do it at the level. But then I just realized when we aggressively put a SPECT-CT and PET scan, then I need a more expensive machine called the cyclotron. Because they produce the FDG. And I only have one cyclotron before. Then I work with the private sector, so they invest in the cyclotron, so they can produce the FDG, so they can deliver these FDGs to several PET scans that we distribute across the nations. But one thing that I would like to get help from IARC, because we can leapfrog. When we started late, we can leapfrog. I knew that the evolving technology in cancer treatment is moving into biotechnology things, targeted therapy, more personalized, immune-based system, gene-engineered therapy. So that's why now we do some research in our National Cancer Hospital for the advanced therapy like CAR-T cell therapies, vaccine cancer. They call it a TIL therapy and whatever, CRISPR, editing, whatever it is in gene editing therapies. So I would like also to work with IARC. So let's open an opportunity for us, so we can also leapfrog and going to more advanced therapies. And I would like to, the reason I want to join IARC, because I want to send more Indonesian people here. Having the money, getting the machine, I learn is easier. But getting the people ready and qualified to run the machine and treat the patients in a minimum standard, it is the most difficult thing. That's why I need to learn from you. I promise I will not take the person from you, but I need to learn from you. Thank you.
Thank you, Minister. I will now pass the floor first to Dr. Comley because he has a trip to catch. If you want to have some final considerations.
Yeah. Thank you very much. I mean, I have told you I have a train to catch, but really I know the next question is hard, so I don't want to answer it. But I did actually just want to say, this point that's been made a few times, Australia has a good position in some things. I think the reason we value an organisation like IARC and actually many multilateral institutions is because there are some things we are learning from others and there's others that we are doing better, and there's always lots that you're learning on the way through. So as well as thanking everyone for inspiring me about which is the next cancer to eliminate, I also think there's always two-way flow, and I'd also say whenever I go to an international meeting and people see we're doing something really well, I do think to myself, you should see how the sausage is made inside our country, and we think we've always got more to do. So enjoy the rest of the conference. Thank you.
Thank you. Thank you, Secretary. Thank you for your participation, and have a good trip back home. Thank you very much. I will go now back to Dr. Alazemi, please. Saudi Arabia is also helping build the evidence base for cancer across the Gulf region. How can regional data and common quality standards now be used more directly to guide national planning inside the Kingdom of Saudi Arabia?
Thank you. In our cancer registry, we have more than 400,000 registered cases. And the registry is really playing a critical role in shaping national cancer planning. A lot of policies now are coming out of the Saudi Health Council based on the data and the information we get from the cancer registry. It also helps in guiding the resource allocation and supporting the distribution of oncology services across the country. Talking about the Gulf countries, as you know, we share many risk factors like obesity, diabetes, tobacco use, lifestyle, related diseases, and those common, causes, in fact, call for a regional collaboration, which will be extremely valuable. So the Gulf Cancer Registry, which was launched with the help also of IARC, and today we hear Dr. Rachel Fawaz also from the Gulf CDC talking about a lot of initiatives and projects, to work at the level of the GCC. In fact, we are working closely with our colleagues in the Gulf GCC to ensure that we benchmark from each other, we exchange, the knowledge and the information. The problem is not, in getting the data, but it's in putting these data in action. That's the most, the interventions which will come out of the policy is what will make the difference. This is why we work on identifying the gaps, screening and outcomes. And in fact, now the next stage is working on the next generation cancer intelligence system, where we will leverage the AI and the genomics, molecular, all the advanced digital health infrastructure and the AI-enabled analytics are also need to be applied, and we are working, whether under the Ministry of Health, under the different entities in the care providing entities. At the level of the policy, Saudi FDA is also generating a lot of policies related to the sugar taxation and salt reduction and hydrogenated oils. All of these are targeted by the policy based on what we get from the cancer. This is why we think strong registries and shared standards are not only technical tools, they are strategic instruments, smarter investment and better policy and earlier detection, and at the end, the purpose is really having a better patient outcome. Thank you.
Thank you. Thank you very much, Dr. Nahar Al-Azemi. Thank you, honored ministers and panelists, for the richness, the openness, and the constructive spirit of this discussion. The commitments and perspectives shared today have reinforced what the science has long been telling us. We understand cancer better than ever before. We have stronger evidence, better data, and much clearer picture of where prevention, early detection, and more effective action can make the greatest difference. The question before us is no longer whether we know enough to act, it's whether we will act with the ambition, the speed, and solidarity the moment demands. Science, data, and implementation must go hand in hand. And because no country can meet this challenge alone, progress depends on sustained international collaboration, shared learning, and collective commitment. IARC was built on the belief that cancer could be understood and that understanding it required the world to work together. 60 years later, that founding vision remains as relevant than ever. With your commitment and partnership, let us turn the knowledge we already have into a reality we still need to achieve, a world free from preventable cancers and with better outcomes for all. Thank you very much. I would invite now the honorable ministers and delegates to come for our official photo and then pass on to the closing.
Thank you very much. Thank you very much, panelists. We could have kept talking for hours on all of these topics. Wonderful to have all of you with us. We have a couple of other people to join also for the photo, for the official photo, to capture this moment in history. The 60th anniversary of IARC at the end of this international scientific conference. A moment for an official photograph, and also for a selfie. I see lots of telephones going up, so that's great. The professionals and the non-professionals. Wonderful, thank you very much. Another big round of applause for our panelists. Thank you very much. Thank you very much. And it really has been about looking forward, hasn't it? It's been about looking forward. We had Blair Comley taking part in the panel also with us. And as part of the closing remarks, just while we're waiting for our VIPs to leave the stage, I'd like to call on another Australian who is going to help us with some closing remarks as we come to the end of the conference. And I'd like to call to the stage now, please, the Chief Executive Officer of Cancer Australia, Professor Dorothy Keefe, for some closing remarks and really looking forward into the future. Thank you very much, Dorothy.
Thank you. I think I better let these gentlemen leave the stage.
Yep, we'll just wait. We have a bilateral meeting going on as we speak.
Let's hope it's in the interest of IARC.
Thank you so much. Thank you so much. Thank you. Thank you very much. Thank you, Dorothy.
Thank you. Director Widerpass Elizabeth, ministers, colleagues, distinguished guests and friends, thank you for this opportunity to offer some closing reflections as we mark 60 years of IARC. It's been a privilege for all of us, I would venture, to spend these 3 days in Lyon watching the theme Cancer Research into Action move from words into practice through the quality of the science, the frankness of discussion, and a genuine shared commitment to prevention and control. I want to first recognise the breadth of community gathered here. We have over 1,300 delegates from more than 90 countries, and that global mix has been one of this conference's greatest strengths and has been on full display in every session. When IARC was conceived in 1965, it was an ambitious idea, a specialized WHO agency to bring countries together around the science of cancer. It was created by the World Health Assembly on the 20th of May 1965, and from a modest beginning with 5 founding countries, has grown into an organization with, I think I can say, 31 members, with Indonesia announcing its joining, and a governance model that supports independence, scientific excellence, and true global reach. Over those 6 decades, IARC has also broadened what it delivers, from early strengths in international epidemiology and collaboration to a portfolio that includes surveillance, evidence synthesis, prevention, evaluation, and support for implementation in diverse settings. IARC's flagship programs, which you'll hear about one more time, include the WHO classification of tumours, the IARC monographs, and the IARC handbooks of cancer prevention, and they provide practical, evidence-based foundations for diagnosis, regulation, prevention, and policy decisions across diverse health systems worldwide. And alongside that, IARC's data platforms, including GloboCan and cancer incidents in 5 continents, provide the global cancer data that decision makers rely on for prevention and control. Over that same period, however, the cancer challenge has intensified in scale and complexity, and in the pressure it places on communities and health systems. When IARC was created in 1965, there was very little global cancer data available. Incidence data was collected for 6 high-income countries and mortality data for 23. Today, IARC's Global Cancer Observatory captures data from 185 countries around the world. The latest estimates from 2022 show almost 20 million new cases a year and 10 million deaths. Roughly 1 death every 3 seconds. And based on demographic change alone, new cases are projected to reach 35 million a year by 2050. These numbers are not just statistics. They represent real people living with the physical and psychological burden of diagnosis and treatment, and families navigating uncertainty and grief. They're a sign of health systems under sustained pressure, and they emphasize why prevention must be central to our work. And yet, we should hold on to the most important counterweight to those numbers. Research shows that up to half of those cancers can be prevented. That is the practical, hopeful center of our work and why this conference matters. It has kept the focus where it belongs, on turning evidence into impact and preventing cancer wherever we can. This conference has been explicit in its objective to translate scientific advances into public health action and strengthen how science informs policy. Evidence-based decision-making is not simply about producing knowledge. It's about ensuring that knowledge reaches the points where it changes outcomes through legislation, investment, workforce design, and service delivery. Across this program, we have heard the same messages in different ways. Prevention is not an add-on, it is a strategy for sustainability. Data is not an end in itself, it is an instrument for action. And equity is not optional, it is how we judge whether progress is real. A special word of thanks to the ministers who joined this roundtable this afternoon. Your presence matters because cancer prevention and control ultimately require political choices and long-term commitment. Responsibility for change is shared between scientists and policymakers, and the impact is greatest when evidence and policy move together. It is encouraging that the roundtable focused on the practical interface between evidence and action. This is where real-world decisions are made that determine whether prevention is funded and whether people can access early detection and quality care. One of the conference's clearest demonstrations has been the value of open dialogue and real collaboration. Cancer does not respect borders, and neither should our prevention and control efforts. The collaboration evident here is not a nice to have, it's how we respond to a growing global burden with speed and consistency achieved through shared learning. That collaborative purpose is exactly what IARC was created to enable. a shared scientific basis for action forged through international collaboration. Looking ahead, the scale of the challenge is clear. If we don't change course, demographic pressures will drive incidence substantially higher in decades to come. But there is cause for optimism. We're getting better at understanding causation and identifying effective interventions. We are improving our ability to implement prevention strategies in real-world conditions where constraints are real and choices matter. This is where IARC's vision resonates so strongly. A world where fewer people develop and suffer from cancer today and for future generations. In other words, to stop cancer before it begins by bringing science into action. In the next 60 years, IARC's influence is likely to be even more central because cancer prevention policy depends on trusted synthesis of evidence in rapidly evolving fields. In a resource-constrained world, countries will increasingly need shared data infrastructure and shared learning on implementation, fields in which IARC excels. Throughout my entire oncology career, IARC has always been there as a single source of truth, a guide to practice and a trusted support. And I know many of you in this room, probably most of you in this room, could say the same. As a medical oncologist and supportive care specialist, I relied on the global consistency that IARC provides. The resources helped me to classify disease, interpret evidence, and translate that into clinical care. As CEO of Cancer Australia, the government's national cancer control agency, I see IARC's work as a practical enabler of national decision-making. It helps governments to weigh risks and set priorities and to invest in interventions supported by robust evidence. Chairing the Governing Council of IARC is a huge honour, and I take that role incredibly seriously. I feel a strong responsibility to safeguard what makes IARC uniquely valuable: the scientific integrity, the international collaboration, and a clear focus on prevention. I intend to support IARC to remain globally connected, including, especially with low and middle income countries, focused on equity and implementation. IARC must be confident in communicating evidence clearly for decision makers, especially where difficult decisions need to be made. I look forward to considering IARC's new 5-year strategy of evidence into action at next week's Governing Council session and to supporting its practical implementation. To close, I want to return to the central idea of this conference: cancer research into action. Marking 60 years is important, but what matters even more is what we do next and how we use IARC's work to make the greatest difference. Over these 3 days, we have seen what is possible when dialogue is open and collaboration is purposeful. My hope is that each of us leaves Lyon with 2 things. Firstly, renewed confidence that prevention and early detection can bend the curve of the future cancer burden. And secondly, a clear sense of what we can do next in our own settings to convert evidence into decisions, programs, and outcomes. Congratulations to IARC on 60 remarkable years. Thank you to everyone who's contributed to a conference that has been thoughtful, practical, and full of momentum. Safe travels, and let us all keep turning research into action.
Professor Dorothy Keefe, thank you very much for those closing remarks. We're going to have the official closing remarks from Dr. Weiderpaas in just a moment, but I did want to just quickly mention it is the 60th anniversary, that's the Diamond Jubilee for IARC. On day 1, I said that I was handing out free diamonds. I've had so many people coming up asking for their diamond, so I have to explain this. After 3 days together, I've actually decided that you don't need diamonds. It's a bit like you've got diamonds on the inside, diamonds on the sole of your shoes. You're shining bright like a diamond. So in fact, there's no point giving you a diamond, because what I've seen here over the last 3 days is people who are already shining diamonds from the inside. So thank you all very much. And without further ado, the official closing remarks now. Let's welcome back Dr. Weiderpaas. Thank you all very much.
Thank you.
Thank you.
Thank you very much, Seamus. Distinguished colleagues, partners, and friends, ladies and gentlemen, as we come to the close of the IARC at 60th International Scientific Conference, I would like to begin by expressing my sincere thank you to all for your contributions, your engagement, and to your commitment to advancing cancer prevention worldwide. Over the past 3 days, this conference has truly lived up to its title, Cancer Research into Action. We have seen how discovery, innovation, and evidence can and must translate into tangible benefits for populations, health systems, and future generations. Across the 3 core themes of this conference, discovery and innovation, translation into public health action, and science policy interface for global change, a clear message has emerged. Science matters most when it's connected to impact. We have heard compelling examples on how new knowledge is reshaping our understanding of cancer causes, from environmental and occupational exposures to behavioral, biological, and societal determinants. We have also seen how implementation research, early detection strategies, vaccination, and surveillance systems can transform evidence into real-world gains when they are designed with equity, context, and sustainability in mind. Perhaps most importantly, we have been reminded that evidence alone is never enough. Progress depends on trust, collaboration, and the ability to translate science into policies that protect health, especially in a world shaped by inequality, commercial interests, and competing priorities. A defining strength of this conference has been its global and inclusive perspective. Contributions from low, middle, and high-income countries alike have underscored a fundamental truth. While the cancer burden is global, its impacts are profoundly unequal. Throughout our discussions, equity has not been treated as an afterthought, but as a guiding principle, whether in relation to access to prevention, early detection, data, technologies, or decision-making itself. This reflects IARC's enduring commitment to ensuring that scientific progress benefits all populations, not only those with the greatest resources. We have also reflected on the broader forces shaping cancer prevention today: climate and environmental change, rapid urbanization, digital transformation, and the powerful commercial determinants of health. These forces challenge us to think differently about how we generate evidence, how we govern innovation, and how we engage with policymakers and the public. In this context, IARC's role as an independent scientific agency within the World Health Organization is both unique and essential. Our responsibility is not only to produce rigorous evidence, but to safeguard its integrity, communicate it clearly, and ensure it informs decisions that serve the public good. As we conclude this conference and close IARC's 60th anniversary year, the question before us is not what we have learned, but what we will do next. The discussions held here must continue beyond these walls, in laboratories and ministries, in communities and classrooms, in global institutions and national health systems. The partnerships strengthened here, the debates sparked here, and the ideas generated here must translate into sustainable action. Cancer prevention is not the responsibility of any institution or discipline. It is a collective endeavor requiring collaboration across science, policy, and society. IARC stands ready to continue playing its part by generating independent evidence, strength capacity, and supporting countries in turning knowledge into impact. Let me conclude by thanking the Scientific Committee, speakers, partners, sponsors, and the IARC team who made this conference possible. And most importantly, thank to you all, the participants, for bringing your expertise, your perspectives, and your passion to this shared endeavor. As you return to your institutions and countries, I hope you do so inspired, connected, and resolute in your commitment to turn cancer research into action. Thank you, and safe travels to all. Thank you very much.
Dr. Elizabeth Bijdepaas, thank you very much. Thank you very much. I'm not going to ask you all to sing Happy Birthday again because Elizabeth and I have already done that. We shared the microphone singing that. But I do want a big round of applause, please, for all of the organizers who have organized this conference over the last 3 days. Also, a big round of applause for all of the staff working in this Congress Center. All of the staff and the technical staff as well. All of the catering staff. Big round of applause for them as well. So thank you very much. Lots of insights, lots of ideas, lots of talking points. Let's go forward. Good luck for your future projects. Good luck for your future projects. And as I always say, keep fighting the good fight. Keep fighting the good fight, and see you at the next conference. Thank you all very much.